Dr. Recht.
Yes.
Hi, how are you? The wonders of modern technology.
It's amazing, isn't it?
It's quite remarkable, must I say.
All right. First, this obviously is not optimal. This is a time of, kind of a strange time, and, we don't like to do videos, but, this is fine. In your case, exam is not part of the deal. Anyway, for the most part, so we can do this by video, save you a 6-hour trip in total at least, so it's good, right?
Yeah.
So, but I want your consent, or at least a verbal consent, so
Sure.
that that this is okay.
That's
Okay,
fine.
so I want to know, are you sheltering in place in this?
No, I'm actually at the office, essential work manufacturing. So.
Really?
So this is
okay. Well, you at least keeping distance?
Yeah. Our office only has a couple people, so two to three people here max. Anyways,
okay, good.
So not a big deal.
Because I'm at home, I'm sheltering in place myself.
Yeah, that's what I'm supposed to be doing.
Older, and I have I live with someone with the risk factors, so I haven't been able to go to work.
Yeah. In retrospect, I'm quite happy to have not undergone chemo, and I have an intact immune system. So that's a-okay right now.
Correct. And how are you doing?
I feel fine. I've always felt fine ever since post-surgical. I haven't felt anything other than normal.
Great. Okay. And you had your MRI, and I just want to know for clarification, did you get a report or anything?
Yeah, I had to reach out to them for the report, but they just basically said there's this elevated T2. I don't know what that means, but something around the margin of the scar that they just want to pay attention to for the next time.
Okay, so I want to talk about that a little bit. Yes, I did see that. First, I have a question. Did you do the scan in the same place both times?
Yes.
Okay, good. That'll be helpful because, when these subtle abnormalities occur, you got to be careful because there's so much difference between machines that sometimes you can't, you really can't be sure.
Right, okay.
So, these things, it's not clear. There is a little, this is one of the downsides of the video visit is until we make Zoom secure, we can't really do this. Otherwise, I could actually, once we could do this on Zoom, I would just put the images up and show you what they're talking about.
Okay.
It is very subtle, but it's adjacent, and I think it's reasonable to watch this. What I would like to do, if it's okay, because I really couldn't see it on the last image, but it's small enough that it might have been missed in the cuts.
Okay.
When they do MRIs, they do them at 1 millimeter distances.
Yes.
And this is below that, so it very well could have been missed. Because you can actually see, so this could still be post-operative. My recommendation is, I think since you have, we've been, I don't have to, I'll review your case more for myself than you. It's really, September, you had the seizure, you had the tumor, you had it resected, so we're now 6 months out.
Yep.
And you had a scan in December, and that looked really quite good. And this scan actually initially looks good until you really drill down on it, and there's this little signal. And what the signal means could be anything. It could be post-operative. It could actually be a little residual of tumor too. That's the issue. That's why we want to watch it.
Sure.
And as you said, it's reasonable since since we're in this era. Sure, I don't really want to jump on treatment either because I don't know what this is. So my recommendation is close follow-up. And actually, I would ask for one scan to be done at 2 months. This next scan to be done at 2 months instead of 3 months.
We've always been doing 2 months.
Let's do it 2 months. Okay, great. Let's do it at 2 months. So that's no difference. You feel okay. I'm inclined to follow, but if I'm just thinking back in our earlier conversations, which were kind of extensive, and I know that you're a detail guy and you want all the information. Having thought this through in the worst, let's just do the worst case scenario. It's a little bigger. It can't be much bigger. I'd be very surprised. It's really not going to do that.
Right.
So if we make an inclination that we might want to deal with this, I think at that stage, I would actually endorse the Topsevo approach. I think what you had been doing, I think that would be really wise because it would be, if this really does work, if the top, it's not clear that in this particular tumor type, it really, how effective it is, because we don't have enough time and enough experience, that we would be, remiss to just say, oh, blow it off and say, yeah, this is what you should do. But it would be actually an interesting, it would be actually very valuable for you to try this. If it's then all of a sudden stops growing or shrinks, we have a very nice, we have a treatment for you that really hasn't burnt any bridges, and we can, we can continue this apparently indefinitely. So,
so if I recall,
I'm sorry, go ahead.
If I recall before, you were concerned about approving the Tepsiva treatment because you were worried about removing the brake, because these are slow growing cells. If we take them away, the underlying metabolic pressure remains, and then something else can grow in their place.
I did in fact say that, and that is, in retrospect, that still applies. I'm watching the literature extremely closely.
Okay.
And they're using this quite, a lot of people are using this. This is really being looked at in studies. There's a lot of enthusiasm. Unless you look at it a different way, unless you look at it in this alternative way, people kind of, when I present this and talk about it, people, nobody's seen it. I'm actually,
show me the data.
So, yeah, and if you really drill down, there are downsides. People have found downsides about going straight with Timidar. Timidar, I think it's overrated, but if you really look at, the Timidar experience over time, it is a mutagen. And so not surprisingly, you find more mutations in your tumor.
Sure.
And while that could be, most mutations are really not harmful, it's still there, and it's there, that theoretical consideration you can find. And frankly, radiation also, where everything we use is needs to be used with clarity and caution.
Sure.
So, and it's all based on the fact of what is going to happen to the tumor. It's a risk and benefit. So, obviously if the tumor is growing and we're worried, we take more chances. If the tumor is stable, and we know that it's kind of based on what all our information, that it's going to be a relatively benign situation. I think I explained this, like if I thought you were going to live 10 years without treatment, why would I give you a treatment now that can give you problems 10 years down the road?
Yeah, that was the conservative approach, and maybe that buys us some time of good life and some time for some development to happen. Yeah, I understand that.
Okay. So, with that said, let me answer any questions.
Okay, so I still didn't get a great response the last time we talked with you about, the underlying metabolic mechanisms that are feeding this glioma cell, and things that I can do as far as diet or whatever, to sort of prevent their, rapid growth. And you basically said at that point in time, I wouldn't recommend you gain any weight. I wouldn't recommend you lose any weight. Stay active, drink water, blah, 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 but there wasn't really any, insight as far as, like if there's something specifically I should, avoid that's going to be pouring gas on the fire. Are you still on that same page?
Yes. The problem is, if there was something definitive, there are a lot of, we could outline some things that generally are truisms. We look at it this way. Tumors, they redirect their metabolism so that they could support growth. And certainly you can correlate growth with the amount that they kind of redirect their metabolism. So you can do that. That's easy. The question is whether you reverse your metabolism, or you could reverse your metabolism, does that, and drive that metabolism back towards normal levels. Can you stop its growth? And the feeling is, yeah, you should be able to do it, but it's very hard to do and very hard to measure. But if you were thinking of ways of kind of diverting energy so that the tumor couldn't use it, there are a couple of, there are strategies that are proposed. Gaining weight is not a strategy. So, obesity makes these these tumors grow faster. Starvation actually slows tumor growth. You're not. I'm not saying you are. I'm just mentioning it. You had said, should I eat more or should I eat less? And starvation, slows tumor growth, but your tumor's growing slowly anyway. I mean, so what you're doing is, pretty good. So basically, a healthy lifestyle is the best, kind of recommendation. If you there are metabolic strategies for tumors. So we talked about a diet called the ketogenic diet. I must have mentioned that because people do. That's a lot of work for you, and that sometimes some people tolerate it, but many people don't like it because it's really removing all carbohydrates from your diet. So it's it's like avocados and steak and eggs and what is that?
It's a big bowl of white rice with cinnamon and brown sugar.
Okay, yeah, that's gone. That's verboten.
Yeah.
And you have to be compliant. I mean, you can't do it 6 days out of the week. You got to do it 7 days, or 1 day ruins it. So yeah, it seems like a lot of work. So some people have advocated using medicines that work. There is some similarities in the medicines that work on type 2 diabetes, because that's a metabolic problem, and it's the idea of getting you to restrict, to change the way you utilize your sugar, and that has been, bandied about. We use a drug called metformin for that, and that should do the same thing as a ketogenic diet in principle, and so that's a choice too, and might give you some, nice thing about it is metformin doesn't lower your blood sugar. It only lowers a diabetic's blood sugar. So you're not at risk for low blood sugar. So there's a nice, it's generally, the only problem is sometimes it makes your stomach upset. And that could be a limiting factor. And in fact, that limits the dosage we can give. And what people don't say, and to be absolutely transparent, is metformin probably is a very good agent, and it would be a good anti-tumor agent, but we can't really give it in the doses we need. So we have to use it in a lower dose. We would have to actually scale it up an order of magnitude, which would be intolerable for you. So we can't really, so we use the dose that we use in diabetes, and we hope that it does what it's supposed to do. But, that's the downside of that, and that's why that hasn't become more of a mainstream kind of agent.
Now, my understanding too of the keto diet is that it's not a long-term solution. I mean, you can only stay on it for 6 to 8 weeks or something like that, and then at that point you have to kind of revert off of it. Is that what your understanding is?
No, my understanding is you're on it forever.
Okay, so you just switch. You're like a vegetarian, you're a vegan, you're a keto now. That's just what you are.
You're a keto now, yeah. And it used to be very, very hard, because it's very hard to prepare. But now there is some health benefits to the ketogenic diet, they're saying. And, so there are in some markets now, they actually have sections where they have ketogenic diet.
It's a business opportunity.
What's that?
It's a business opportunity.
It's a business opportunity. And some people, some people claim it's quite palatable. If you were interested in doing that, I would actually you need a nutrition consult to sort of get that in order.
Okay.
And it really doesn't hurt. You always lose weight on it, so there's a lot if you're compliant. It used to be thought to be a very unhealthy diet because it's all really, it's fat and protein.
Yeah, it's polysaturated fat and protein. Yeah.
It changes your metabolism in a way that it's actually quite, that has some very beneficial effects. It's a hard lifestyle change. I mean, you've had enough kind of life-changing events in the last year. I mean, I don't want to really, and you have I still think I'm very bullish about your prognosis, et cetera. I don't know that you want to make that kind of change in your life, but.
No, I just want to know what the options are. And like I said, that's why I sent you that other email asking for information about there was some scavenging agent or something like that, and you were neutral. on that. But that's some other people I was talking to that mentioned that might be a good thing for glioma patients.
So they would like the antioxidants you're talking about with that
The
kind of scavenging?
Yeah, something in red wine, some scavenging agents. Yeah, something
Well,
like
that's
that.
Revastorol. Yeah, there are some of these things. So the idea of that is, it's not that that's hooey. That actually makes a lot of sense. But the problem is you can't measure if you don't. It's a titration with those kind of treatments, and we have no way of knowing whether we're titrating right. So if you do too much or too little, it's not right. And just hitting that point without a test to tell you, it's like having diabetes without knowing anything about blood glucose.
Oh,
You
okay.
wouldn't know what to measure, so you'd be changing things, and people would say, well, you shouldn't have sugar, or it'll get you into. So we have no way of monitoring.
Okay.
More likely, like a blood pressure. Also, you have a
Yeah.
heart attack, they want to treat it. They know something's wrong, but they can't measure your blood pressure. What do you do? Well, you give this medicine, and so you would be getting, these these medicines and not being able to measure their effects, and people would be dying from, low blood pressure.
Right.
So that's the problem, and I think in the future that might be the way that it will go. But until there's a test.
Okay, so we don't have a measuring stick. There's no point to blindly shoot it in the dark at this point.
I don't think so.
Okay.
I mean, you're happy, you feel well.
I do. I do.
And the problem, it's like, empathy is difficult because I can't walk in your shoes.
Sure.
I could walk in your shoes, but obviously that's not sanitary. But I mean, I can't, not having had this, I can't really, I just do this. It's a little vicarious, but I do understand because I've lived. So this is like living with a time bomb. You don't know what's going to go. You feel great.
Right.
And, you don't even know if it's set to go off. You're just there, and you just want to, you want to keep it from detonating.
Right.
I get it. And if I had something, that's my job also. So we have the same job. And so I kind of also live on, I feel like I'm walking on eggs. I mean, it's very hard because I want this to be optimal. And I have realized that when you take drastic solutions, if you don't really cure it comes back to bite you. So if you do wide exonerations, or you give over radiate, with the idea of too much is really not good in these kind of tumors. So it's not like leukemia, where the idea is to obliterate everything and then put it back.
Right.
We can't do that with your brain.
Right.
It's not a good idea because we can't put it back. We have no way of reassembling once we disassemble. So we got to be careful. So I will pledge that I will do everything possible, and more importantly, I will try to convey the information. So I don't want to increase your anxiety, but you're a kind of person that I think information allays your anxiety, and you realize that it's a little bit like in this epidemic. Everybody's telling you what to do,
right?
But they don't really know, because they'll know in a couple of years what to do,
right?
Because then they'll have the experience, and they'll be able to, they have enough of a sample now that they can do it statistically, and they'll tell you what will work. But now, we're guessing. We don't know how long to stay in place. We don't. These models are very much like predicting the weather.
Right.
They do simulations. That's how they predict the weather, and 95% of the simulations come out this way, so they assume it's correct. But if they did it a different way, it would be different. So, we have to forge on, because you have a life to live.
Sure.
And your life is an individual life, as opposed to the million other people that have this, is unique, and so it will obey a unique course.
Right. Okay.
So everything is good. There's also one other. I'm sorry. I just so I want to be reassuring, but I want the MRI in 2 months.
Yep.
And, to send it with me, and also I want you to send me their report, because they didn't send me a report.
Okay.
I just want to see what they're saying. I don't need their report for my interpretation, but I want to just make sure that they're on the same page.
I think I can copy and paste the little thing that just said, elevated T2 levels. I'll get a.
That'd be great.
Yeah. Let me see if I can get that over to you in a message. Also, in the effort of full transparency, I wanted to bring you up to speed on the fact that randomly I ran into a gentleman down here in Santa Barbara who actually lives up in the city, up in San Francisco, and sat next to him at a wine bar and struck up a conversation. Turns out he's got the exact same anaplastic astrocytoma, same mutation, same everything that I have. And he recommended a gentleman who he put me in contact with, who's your counterpart at Dana-Farber. And
Which one? Patrick Wen? Who?
No, Dr. He's the head of neuro-onc at Dana-Farber. Dr. What the hell's his name? Tracy Todd Batchelor.
Batchelor, right. He's no longer at Dana-Farber. Now he's a chair at Beth Israel. Yes. Sure. You could talk to him.
Yeah. So.
No, I know Tracy.
Okay. Yeah. So I'm talking to him through DFCI, and I have a video conference lined up with him to discuss my case next week. And the fact that this whole epidemic thing is hitting right now is kind of good for me because I don't have to fly out to the East Coast and I can do a video chat and I don't have to pay for grand rounds. So another data point. I mean, I don't know if it'll be beneficial or not. I'll definitely keep you in the loop as to what he says. I kind of want to just, at this point, was sort of ready for another, it's been a few months, just ready for another data point. Doesn't mean I'm going to drastically do anything with it, but, I think it's, might not be a bad idea, to hear from this other gentleman's experience. He actually did do the full chemoradiation route, and he's 6 years post and doing relatively well. He does have some cognitive loss a little bit, so that's another data point that makes me say I don't want to do that if I can avoid it. And we talked about, standard of care and blah, 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 all that stuff. So I kind of just want to hear what this guy, Tracy, has to say.
Sure.
So
absolutely.
So that's where I'm at with that. And I'm happy to just kind of keep you guys all filled in the loop. Dr. Lai down at UCLA, he also got a chance to look at those images and he agrees with you, let's pay one more close look at this thing on the next scan. So he's also sort of monitoring the situation, and I don't know, more brains, more better, right? So that's where I'm at.
Excellent. Very good. I think that's great. Say hello to Tracy for me.
Okay, I will. Yeah, it was just a very random occurrence that I just happened to encounter this gentleman.
He's very well known, and he's a very he will handle it. He's fairly aggressive, so it was might give you a slightly different approach, which is fine.
Yeah.
You can hear it, you can weigh it in. Just gives you an idea of expertise and how years of expertise make some people on this camp versus that camp, and it's
right.
That's what makes it so confusing for patients, because you say, well, why that's fine, and you seem to be okay with that, and you could balance it. So
sure.
That's great.
If
you need more names, I'll give you more names.
No, I don't care about that. I mean, what I want to know is how come you guys are all Harvard, Boston guys? Why is it all is that the epicenter?
The epicenter was the epicenter, you'll notice, is in New York.
Oh.
Everybody can trace their name. Everybody who's anybody in this business somehow has less than 1 degree of separation from Jerry Posner at Sloan Kettering.
Okay.
Who starts this. So Jerry trained both Tracy and me, and actually, while he didn't train Dr. Lai, Dr. Lai's mentor, Dr. Clousey, is also memorial trained. So it's one of those things where this guy spawned, essentially the entire country kind of traces to him.
Huh.
So at some point, we all go through Sloan Kettering.
And then also my surgeon, Dr. Park.
I'm sorry?
My surgeon, my neurosurgeon, Dr. Park.
Yeah. Also is from the East?
Yeah, he's Harvard.
Yeah,
brain surgery.
There's plenty of, if you keep good, there's plenty of people who are trained in would consider themselves Californians.
Right.
I'm not, I guess,
Well, hey, it's easy for Santa Barbara.
Now I am. Now I'm definitely a Californian.
Well, there you go. Yeah, I mean, I think Santa Barbara cherry picked him and he wanted to be on the West Coast. So, that's a thing that happens.
That's what happens.
Yeah.
All right. Well, let me get you back to work. And,
okay.
We'll keep in touch. Please give me the blurb that they sent you so I can have it in the record.
Okay.
Good luck with Tracy. 2 months, and we'll make another video visit. And in fact, for you're the kind of patient that after this epidemic cools off, we'll still do video visits until we absolutely need to do it in person.
Okay, great. Sounds good to me.
Okay?
All right, thank you.
All right, enjoy your day.
All right, talk to you
Stay
later.
safe.